Hello, everyone. Welcome to Human Life of Washington, or affectionately known as HLW, our very first legislative brown bag for 2022. Today, we'll be focusing on one bill, House Bill 1141, increasing access to the Death with Dignity Act. My name is Sarah Davenport Smith, and I'm the lobbyist for Human Life of Washington. Today, it's going to be my pleasure to introduce three experts in this field of end of life issues. If you have any questions for us today whatsoever, please send all of your questions to info@humanlifewa.org. All right, with that, let's get right into these presentations. First, I would like to introduce you to Richard Dorflinger. Richard Dorflinger is a policy analyst on end-of-life issues. He's a fellow at the De Nicola Center for Ethics and Culture at the University of Notre Dame, and he is a Washingtonian currently living in La Conner. Richard, thanks so much for joining us today.
Oh, thank you, Sarah. Well, my job is to set the scene here, give you some policy information. In 2008, Washington voters approved that what's called the Death with Dignity Act, allowing physicians to prescribe what the act calls lethal medication, so patients expected to have less than 6 months to live could take their own lives. Supporters promised the act had ample safeguards against abuse. Physicians had to comply with these and report to the Department of Health on how they'd done so within 30 days. Failure to comply with that made them subject to existing criminal law, which punishes assisting a suicide as a felony. The weak link is that this is self-reporting. The prescribing physician tells the state, I complied with the law, and others have to accept that as true. The Oregon Health Division once said of their very similar law, as far as they know, the doctor's account could be, quote, a cock and bull story, but you still have to accept what the doctor says. HB 1141 would expand this act by weakening or eliminating those safeguards that the voters were promised. It would allow physical and psychological assessments by non-physicians, allow lethal drugs to be sent by mail, messenger, or parcel to a patient's residence where it could be received by others, and shorten or in some cases eliminate the waiting period, giving patients time to reconsider. About that loss of the waiting period, my wife would have qualified for same-day lethal drugs years ago when I rushed her to the emergency room with toxic shock syndrome and her kidneys were about to shut down. Instead of pausing to tell her about all her options, though, medical staff raced to save her life, though they seriously doubted they'd be able to do so. Well, 18 years later, my wife just returned this morning from her usual 4-mile run. We don't, especially when people are critically ill, we really don't know what their prospects are. And to say, now we're going to pause and tell you about your right to take drugs so you can die in an hour instead of in 3 days, how does that help anyone? It endangers people. It's playing a dangerous game with some people's lives, it seems to me. But now we have the supporters saying that supporters of 1141 say the Act's safeguards work all too well now, and they're really over strict as barriers to access. The Department of Health has now released its annual reports, very late in the game, for the 2019 and 2020 cases, and that allows us to test this claim. Is this too strict? Well, the number of cases grows dramatically every year. The 252 Washingtonians known to have died from the lethal drugs in 2020 is 7 times those who did so in the law's first year. And that's without counting another 41 cases of people who died where the state doesn't even know what the cause of death was. Many terminally ill patients suffer from treatable depression, yet in 2 whole years, no patient is listed as having received a psychological evaluation. Dozens of patients diagnosed as having less than 6 months to live have apparently lived for years. The state has no death certificate for them as long as 9 years later. That's the current law. Most alarmingly, in these last 2 years, prescribing physicians didn't even bother to claim that they had complied with the safeguards in over 6 dozen cases. They never filed their legally required report on the patient having a terminal illness, life expectancy of 6 months or less, informed consent, or mental competency. In over 7 dozen cases, they never sent in the patient's written request for the drugs, a request that has to be signed by 2 witnesses testifying the patient didn't act from undue influence or coercion. We simply don't have those reports. In these many dozens of cases, we have no evidence at all that the patient had a terminal illness. And it seems to me that fully justifies disability rights organizations' concern about dangers to their members. We don't know that the patient's request was voluntary or even that it was made by the patient rather than someone else. All we know is that a physician prescribed a lethal drug overdose with instructions on using it to cause death. And the only reason we know that is because some of the others involved, like the pharmacist who gave the drugs, filed their own legally required report saying that they had provided the drugs to such and such a patient. Yet, in these reports, the Department of Health lists all those cases as cases where the lethal medication was provided, quote, under the terms of the law. Clearly, those many dozens of cases violated the law and could be prosecuted as crimes. Under current safeguards, then, the law in practice is out of control, posing a grave threat to patients. The need is to investigate this cavalier neglect of the law by physicians and, it seems, by our own Department of Health. To loosen the law further now would place more of our citizens at risk and suggest that our legislature just doesn't care whether there are safeguards and whether they are enforced to prevent coercion and abuse. HB 1141 should die so that we and our loved ones can live. Thank you for your attention.
Thank you, Richard. I really appreciate you bringing to our attention the current issues that we're facing. And so you gave us a reality check. And so thank you very much for that information. Next, I'd like to bring on Dr. Sharon Quick. She is retired from work as a pediatric anesthesiologist and critical care physician. She has experience in pain management and the care of dying patients. Currently, she is completing her final semester to earn a master's degree in bioethics. And Sharon, you're going to share several more specific concerns that we have with House Bill 1141.
Yes, thank you, Sarah. Welcome, everyone. Give me just a minute to share my screen and bring up my, my slides. This bill reduces the waiting period from 15 days to 72 hours, or eliminates it entirely if life expectancy is less than 72 hours. Lethal overdoses are unnecessary and medically contraindicated when a patient is within 72 hours of death. A physician cannot conclude that a patient is close to death, this close to death, until signs of organ dysfunction are present. That is, death is already in process with no reason to give lethal drugs. Furthermore, patients within a few days of death have declining brain function and difficulty taking liquids. Therefore, virtually no patients within 72 hours of death would have adequate decision-making capacity to decide to take lethal drugs, nor would they likely be able to ingest them. I would expect complications if they tried. With a high incidence of patients dying from choking on their vomit, lethal drugs do not guarantee a peaceful death, even for patients further from death. They can cause burning in the mouth, vomiting, choking, and can take hours to days to work, with occasional patients waking up not dead. Secondly, specialists are frequently wrong about the 72-hour prognosis. Yet this bill does not require specialists nor even physicians to make this complex determination, and no second opinion is demanded. Eliminating the waiting period is medically irresponsible and sets up patients for abuse and coercion. This bill implies that hastening death is an urgent need, such that the waiting period needs to be shortened. This is not true. Pain and other symptoms can be handled with palliative care. Sedation can always be used as a last resort, so that patients should never have intolerable suffering. Well, what about the testimonies from last session from people who wished for their loved ones to receive lethal drugs more quickly? My heart was heavy listening to them. But my concern was not because they did not get lethal drugs quickly, but because they provided evidence that their family member did not have adequate palliative care. One person whose father had been in pain from cancer was told by the doctors that his dad was maxed out on morphine, such that his only alternative was lethal drugs. However, there is no maximum for morphine in terminally ill patients. Multiple other medications and interventions are also available. Pain should never be a reason to seek lethal drugs. Rather, making it easier to get lethal drugs, we should be ensuring that patients have access to good palliative care and that physicians are not deficient in their use of it. Doctors are often wrong about patient survival estimates, and some patients live years beyond their 6-month estimate. Rushing to put lethal medications into patients' hands does not allow time to discover this misjudgment. Urgency is warranted to treat patients' pain and other symptoms, but there is not urgency to hasten death. Some minorities and disadvantaged groups encounter barriers to receiving palliative care. It would be a tragedy for these populations if removal of safeguards made lethal prescriptions more accessible than palliative care. Terminally ill people have emotional ups and downs that can lead to impaired judgment and frequent mind changes. Emotionally fragile, hopeless, or exhausted terminally ill patients may make unreasonable treatment decisions even when they pass evaluations for mental health problems and decision-making capacity. When patients are given time and support, they often have renewed hope and change their minds about hastening death. Evaluating and treating physical and mental health issues requires more than 72 hours and perhaps more than the current 15 days that are allotted. Antidepressants take 2 weeks to work and longer for maximum effectiveness. Shortening the waiting period does not provide sufficient time for patients to change their minds. Therefore, this bill does not give patients more autonomy, but removes options by preying on patients in their most vulnerable moments, allowing their rash decisions to become their last ones. A physician's role is to value patients' inherent, unchanging dignity, no matter what that person's condition or social situation. When physicians supply lethal drugs to patients who may be in a vulnerable period of temporary despair within this short time frame of 72 hours, they are condemning a patient's life as so worthless because of loss of function that a trial of palliative care is unwarranted. Such actions violate physicians' duties for benevolent care and disregard patient dignity. The Department of Health's 2020 report shows end-of-life concerns for those requesting lethal drugs. Of the top 5 concerns, 4 of them, the starred ones, less activities, feelings of loss or of autonomy, loss of autonomy or dignity, or feeling like a burden, can be symptoms of depression. Those with disabilities may have all of these concerns whether or not they are terminally ill. Depression is common and yet difficult to diagnose, underdiagnosed, and undertreated in the terminally ill. Psychiatrists think patients with major depression are not competent to make decisions about assisted suicide, and they recommend specialized forensic psychiatrists to make complex determinations about decision-making capacity and mental health in the terminally ill. Only 6% of non-specialized psychiatrists were very confident that they could adequately assess the presence of a psychiatric disorder impairing the judgment of such patients in a single visit. Out of 334 people who died in Washington in 2020, one might expect over 100 patients to have depression, but a negligible number were referred for mental health evaluation. This means that physicians are likely missing the diagnosis of depression and patients are inappropriately being given lethal drugs. This bill would exacerbate the existing problem by lowering the standard of expertise for evaluation and not providing adequate time for treatment. This is unjust and discriminatory, as those with mental health problems and disabilities are inordinately affected. This bill is not good for Washington.
Thank you so much for that, Dr. Quick. Everything that you presented should cause people pause, especially our legislators, before passing this bill. And we hope that they will choose not to pass House Bill 1141 for all the reasons and many others that you just mentioned and that Richard shared already, that we have problems with the current law as it is. Thank you very much, Dr. Quick. I'd like to now introduce you to another expert in this field, and his name is Conrad Reynoldson, and he's going to be showing you kind of the thoughts and the position, especially from our population who is at the most vulnerable for these kinds of laws, and that's our people with disabilities, our friends and neighbors and family with disabilities. Conrad Reynoldson is a disability rights attorney and advocate in Seattle, Washington. Conrad works as the VP of the nonprofit disability rights law firm of Washington Civil and Disability Advocate, and is also a commissioner on the Washington Committee of the U.S. Commission on Civil Rights. Conrad, thank you so much for your time today.
Thanks, Sharon. As someone who has a rare disease that is often, whether correct or not, considered terminal, physician-assisted suicide is a deeply personal issue for me. When I was diagnosed with Duchenne muscular dystrophy at age 3, the doctor told my parents that I would not have quality of life and that I would not even live to see my 18th birthday. However, as I write this testimony and speak with you today, I am a 35-year-old civil rights attorney and, as Sharon was mentioning, around Washington Civil and Disability Advocate. And I may require the use of a non-invasive ventilator 24/7 and have numerous other medications and medical interventions. My quality of life is still incredibly high. I live a purposeful and fulfilled life and have great hope for the future. Physician-assisted suicide would be completely inappropriate for someone like me. And yet, an uninformed medical professional without specialization in my disability, merely looking at my diagnosis, would assume that I should already be dead and that I likely would have less than 6 months to live. If I did not have a family and care team like mine that is completely committed to protecting me from an often dangerously ignorant and uninformed medical profession, I would be at great risk of death by ableism if I were hospitalized for an acute crisis, especially if it involved a mental health component. Under House Bill 1141, the waiting period would be reduced all the way down from 15 days to 72 hours. The provider could then waive even the 72-hour period, as we were discussing. A bad day or an acute but treatable medical emergency should not potentially mean a death sentence, possibly even hours later. And there's simply no time for patients to reconsider and perhaps change their minds, or consult with their loved ones or get a second opinion. I am also particularly concerned that under this bill, the patient can undergo the entire process for obtaining assisted suicide drugs, seeing only a single physician. Expanding the law to allow those with lesser qualifications to diagnose and determine eligibility is against the patient's best interests. In fact, Medicare bars nurse practitioners and physician assistants from certifying the terminal prognosis of 6 months survival for hospice eligibility. That 6-month prognosis, an essential function of the attending provider under assisted suicide laws, should not be given to less qualified professionals for the more serious and irreversible purpose of prescribing these lethal drugs. It is already possible for a physician of any specialty to write a script for this prescription under the assisted suicide law. This expansion would allow medical professionals with less training in an unrelated specialty to write lethal scripts. Given my disability, I know how important it is to leave care for people like us to specialists. Medical professionals with less training are not adequately equipped to care for people like us, let alone make accurate determinations on life expectancy and/or quality of life. It would be irresponsible to change this under the law. Removing necessary safeguards from these laws presents a grave danger to vulnerable populations who can easily be coerced or pressured into making this permanent life-ending decision. At the hearings in the Senate and House on this bill last year, the bill's supporters provided their anecdotes identifying delays people experienced and the resulting suffering. Meanwhile, testimony opposing the bill was presented to show why protections must stay in place. People with disabilities often don't have proper pain control or are perceived as having lives not worth living. The lack of clear information on what is working and what is not working under the law resulted in a narrow 7-5 decision to move the bill ahead in the Senate Health and Long-Term Care Committee. Several senators who voted for the bill said that they had deep reservations, but they were willing to let it continue. And the hesitation of the committee members is clear from their discussion. People sometimes dismiss slippery slope arguments as a fallacy. However, in this case, I think it's important to be aware of the broader goals of many proponents. For example, back in 2007, former Washington Governor Booth Gardner, a sponsor of the original initiative, made it clear in an interview with the New York Times that this was simply the first step. He also wanted people with disabilities who did not have terminal conditions to be included under these laws, like what is done in countries such as the Netherlands. The interviewer pointed out that, quote, Gardner's campaign is a compromise. He sees it as a first step. If he can sway Washington to embrace a restrictive law, then other states will follow. And gradually, he says, the nation's resistance will subside, the culture will shift, and laws with more latitude will be passed. Offering assisted suicide to people with disabilities, but suicide prevention to quote-unquote healthy people is ableism and discrimination at its core. If we as a society are to continue to advance disability rights, we must not accept this better dead than disabled paradigm. Loosening the existing safeguards in our state would only move us further in the wrong direction. Thank you.
Wow. Thank you, Conrad, for sharing that information with us and your personal testimony on this subject as well. And we hope all three presenters and myself, Human Life of Washington, and our large and growing list of people who are against this bill, we want you to consider all of these points, and we want you to think about the solutions instead of passing this bill. What we need is better and increased access to palliative care. What we need is support. What we need is a community to surround people who are very vulnerable, especially those with disabilities. We need them to be helped. It was very chilling to hear Conrad's statement of the better dead than disabled, and it's a harsh phrase, but I think it's very accurate in what we're facing, and especially in light of what's happened in other countries as they long time ago started exactly where Washington State was or is, and now they are so much further, full on euthanasia, even for children. children with disabilities. And that's not where we need to go as a state. So thank you for your time. And again, if you have any questions of myself, Human Life of Washington, or any of our presenters, we will get you in touch with them. Just send your questions to info@humanlifewa.org. Thank you for your time.